As introduced, I am Upile Napolo, coming from the Health Economics and Policy Unit, and I will be taking you through a presentation on assessing the impact of introducing kidney transplant services in Malawi's healthcare system using the Thanzi La Onse model. So this is an outline of my presentation. To give a brief background and introduction, CKD and its progression to end-stage renal disease has not been truly identified in its prevalence, but it still represents a significant escalating public health crisis. Across the African continent, CKD currently accounts for 4 million disability-adjusted life years lost annually and has an estimated prevalence of 13.9% in sub-Saharan Africa and mortality rates reaching up to 80% amongst those with end-stage renal disease. And currently in Malawi, the national strategy is that we treat stage 5 kidney disease with conservative management as well as chronic hemodialysis. However, in such a setting as ours, this is intrinsically flawed because these main areas, high cost, limited infrastructure capacity, and demonstrably poor long-term outcomes make this not feasible and very, very flawed. So in contrast to chronic hemodialysis, we have another option for renal replacement therapy, and this is kidney transplantation. And this is definitely more advantageous than chronic hemodialysis because it outweighs hemodialysis in long-term cost savings, reduced mortality, and substantial improvement in quality of life of the patients. And currently, the status quo for a Malawian to receive a kidney transplant is they need to be identified by the Ministry of Health and referred to India to get a kidney transplant. But this, as of 2012, cost about $30,000. And I've used 2012 because the data that's available right now is from 2012. But we all know that since 2012, we have had multiple devaluation, and this number is definitely not indicative of how much it would cost right now to send somebody abroad for a kidney transplant. And even though the government of Malawi identifies these individuals to go for kidney transplantation, this is haphazard because we all know that in our funding landscape, the funds are not as available as they were. So the objective of this study was to evaluate the potential public health and economic impact of introducing integrated kidney transplant pathways into Malawi's healthcare system, specifically at central hospitals compared with the continuation of the current dialysis model. So by employing the Thanzi La Onse model, we want to compare these two scenarios, the status quo of chronic hemodialysis versus implementing kidney transplants into our services, so that when we are informing our policymakers, we have evidence-based models to inform a high cost but also a high impact implementation. Like I mentioned, as of 2012, to send somebody abroad for a kidney transplant costs about $30,000. But if we compare with the status quo of hemodialysis, it would cost about $20,000 per patient per year. The national health budget as of 2012 was $126 million. And at that time, there were 35 patients within Malawi who were on hemodialysis. And to take these people and put them on dialysis for the whole year took about 4% of the budget. So you can imagine that 4% of the national health budget was being taken by only 35 patients, which goes to show you that chronic hemodialysis is very, very expensive. And if we look at the regional level in South Africa, the average cost per patient of hemodialysis is $25,000, and this was taken from 2012 as well. And similarly, in Tanzania, the annual cost requiring dialysis 3 times a week would cost about $27,000. So the methodology of this study, like I mentioned, is using the Thanzi La Onse disease model. This is an all-disease whole system model. So unlike other disease models, this one caters for all the diseases that are taken within the Malawian healthcare system. And what makes this one unique is that it caters for all the demographics of the Malawian healthcare system, looks at the risk factors, the infectious diseases, NCDs, other comorbidities, but it also is able to capture the health-seeking behavior behavior and the adherence of treatment of the patient within the Malawian healthcare system. And we hypothesize that kidney transplantation economically dominates hemodialysis, being superior in projected health outcomes and lower projected lifetime costs. And we developed a treatment pathway that I'll take you through, and we simulate 2 scenarios. So the model inputs include clinical outcomes, resources, such as workforce, equipment, and medication. So the transplant care pathway. All right, I hope you can see this. All right, so when a person interacts with the healthcare system, we're going to start at the level in which they are diagnosed with chronic kidney disease. So this is how we simulated it in the Thanzi La Onse model. So a person is diagnosed with chronic kidney disease using a urine dipstick, UNEs, as well as an ultrasound scan. So after they have been diagnosed with chronic kidney disease, they are then put into 2 stages, stages 1 to 4 and stage 5. So these are the 2 groups. Stage 1 to 4 ends up at renal clinic and on medication, but in stage 5, they have 3 outputs. So it's either they go to conservative management, and in the preliminary data collection, for those who are in the southern region and end up at Queen Elizabeth Central Hospital, 98% of those with end-stage renal disease end up on conservative management due to various factors. And if you're not on conservative management, you will then be taken to a pathway of chronic hemodialysis. And only 2% of those with chronic hemodialysis with end-stage renal disease end up on dialysis. So in this, they have 2 outputs. They'll either not progress in their disease and remain on dialysis for at least 10 years, or this results in death. And now we are trying to integrate kidney transplant into our system, so this is the pathway. So if somebody has end-stage renal disease, they are referred to a renal transplant center where they have a transplant evaluation. At the transplant evaluation, they go through a series of 5 examinations: medical, surgical history, blood tests such as HIV, Hep B, imaging, tissue typing, HLA, as well as cancer screening to make sure that the person is fit for kidney transplantation. From there, they could either have a successful evaluation or a failed evaluation, in which they would go back to chronic hemodialysis. But if you have a successful evaluation, you would either be put on the waiting list or get the transplant surgery. From the transplant surgery, you could either be put on the transplant, you could have a successful transplant and then put on anti-rejection drugs for life, or you could result in graft failure, leading to death, or going back to chronic hemodialysis. So this is the simulated transplant pathway for the Malawian patients. So this study is still being undertaken, so we have not completed the data collection. But on the preliminary results, if we compare kidney transplant from a cadaver, which is like a non-living patient, if you take an organ from a non-living person, or from a living donor, chronic hemodialysis, these are the direct costs in the lifetime of a patient. And from here, we're able to appreciate that in the lifetime of a patient, they would use over $1 million while being on chronic hemodialysis. But if they were to have the kidney transplant, they would use about $107,000 for a living donor and $60,000 in their lifetime if they got a kidney from a non-living person. And these are the levels of effectiveness. So here you might see that chronic hemodialysis looks to be slightly more effective in reducing the disease burden compared to kidney transplantation of a living donor. But this is only because chronic hemodialysis caters to more people, and chronic hemodialysis is less specific, requiring testing. But you will see that in order to avert a DALI, it would cost you $15,000, which is much more expensive than trying to avert a DALI if you gave somebody a kidney transplant. So this is just a representation and an economic evaluation of the different renal replacement modalities. So in the next step, we're completing the data collection. We want to confirm health worker time needed, run the simulation, and by December 2025, we'll have a clear indication. And finally, the conclusion is that kidney transplantation within the Malawian context is very achievable. We have the expertise, we have the general surgeons, we have the urologists, we have the nephrologists, but what is required is health system readiness. And what is very, very crucial to maintain within our health system is the maintenance of the post-transplant immunosuppression supply chain. Because having a kidney transplant requires you to be on these immunosuppressive drugs for the rest of your life. And if we fail to target this particular aspect of the healthcare system, you'll find that even though we've introduced the kidney transplants, there will still be high morbidity, and this will risk graft failure, which is actually more costly and more expensive and catastrophic to the economy as compared to the chronic hemodialysis. These are my acknowledgements. I'd like to acknowledge my supervisors, our partners, and those who are with me in this. Thank you.